Hey guys, this is Mike from PhysioU, and I'm here with my guest, Dr. Wang from Daling, and he is from a visiting scholar at the USC Keck Medical Center as a rehab specialist. He's in charge of a big rehab department at a top hospital in China. And today we're going to spend some time talking about wrist sprains. What is a wrist sprain? How should we manage it? How do they manage it as rehab specialists in China? And just some basic concepts on why it is so hard to decide what is actually injured in a wrist sprain. So, first question I have for you is, what is a wrist sprain? Well, based on the physician model, a wrist sprain is essentially a fall on an outstretched hand and negative findings on a radiograph. So it's not a fracture. It's a soft tissue sprain or strain of some sort. So think about that. A fall on an outstretched hand, some type of trauma, but no signs of fracture on radiograph. Therefore, you have a soft tissue sprain and strain. So the question I have for you then is, what is the source structure? How do I target my intervention? What do I do when someone has fallen, their wrist is so far out of neutral, they have stressed some structures? What are those structures that are involved? Well, in this particular 2012 study, they looked at a number of patients who are in the ER for wrist sprain. They've done their radiograph and their examination, and they found that yes, there is a mechanism of injury, fallen outstretched hand, and no, there is no sign of fracture on the radiograph. They have diagnosed this patient as a wrist sprain. What they end up finding is that within the MRI, one day after the initial exam, all of these patients came in and they did an MRI on these patients. What do you think they found in the MRI? What is the source of pain for wrist sprain? What they actually found was there was high incidence in ganglion, high incidence in bony bruises, high incidence in ligament sprains or ligament inflammation, all these TFCC tears and inflammation. All of these structures in the wrist and hand are all potential sources of pain. So the question I have for you then is, do I target a particular source tissue to manage the sprain and strain? Or do I follow a guideline-based concept that says, with movement coordination impairments, when my injury was caused from being in a position where the joint is too far out of mid-range, and on top of that I've added some significant force? There's a number of different structures, source tissues. So I'm curious, Dr. Wang, when you guys are in China and you see the patient who's coming in with a wrist sprain, how do you usually manage this type of patient?
Yes, in China, most patients must be used brace to limit his risk, and must limit this risk several weeks, 3 to 6 weeks. But
so 3 to 6 weeks of immobilization,
yes.
Keep the wrist near neutral,
Yes.
to rest the structures. So you can see that the intervention is not one source tissue targeted. It's just to allow all the tissues to rest and recover.
Yes.
Okay, and then what?
But after several weeks limited, the risk range of motion also is limited. Yeah, so the PT must pay attention to enhance the range of motion. Yeah.
Right. So, interesting. What was once a movement coordination impairment, an injury that occurred because the tissue was too far out of neutral and stressed the capsule, whatever tissue structure. After the mobilization, the patient has transitioned from one category, which the treatment rehab concept for managing sprains and strains is always to immobilize and let it rest in neutral. They have now transitioned into becoming mobility deficits, at which point then the focus of the rehab, restoring the patient back to function, is now to start restoring the range of motion that they have lost because of the immobilization. So a transition from movement coordination impairments to wrist pain with mobility deficits. If you'll notice, this is the same story that occurs after shoulder or after elbow immobilization, after knee immobilization. They tend to be very painful, lax in the beginning of the injury. We immobilize it and we rest it for a time period, and then we slowly restore the range of motion because they've transitioned to mobility deficits, and then we restore strength and functional movements that are ideal. So, in summary for this Mentoring Minutes, I want to give you a glimpse of what are the source tissues, what is a sprain strain. Remember, a sprain strain can include so many different structures, which means a source-based targeted intervention is unlikely to be very successful because there's so many possible sources. In fact, we just want to put the joint or the tissues in its open-packed, most relaxed position and minimize the use of that tissue. This is the typical management strategy. It's the right thing to do. And from there, as the symptoms go down, the inflammation improves, we begin to take it to the next phase. They are no longer pain and inflammation dominant. They are now range of motion limited, and we restore them with range of motion. Once that is done, we restore their strength, their functional movements, and the patient is now no longer disabled. Right, so it's interesting to hear the East and West concepts of managing the wrist sprains and strains are very similar. Hope that is useful for you guys. Thank you, Dr. Wang, for your expertise, and hope that's useful for you guys. Make sure you check out the PhysioU apps for more information about managing wrist sprains and strains. All right, guys, have a good one.